Welcome to the 2025 Academy of Medicine of Cincinnati EMS Protocol Training. I'm Dr. Tom Charlton, co-chair of the Protocol Committee. This year represents the 50th year of the Academy providing these EMS protocols. I would like to thank everyone over the last 50 years for their contributions to this remarkable body of work. This year also represents the first time the tri-state area has one unified set of protocols that encompasses state-specific information. This means that all of the Greater Cincinnati agencies using these protocols will carry the same version. A special thanks to the subgroup that worked on bringing in Kentucky and Indiana changes to the protocol. As is typical of physician presentations, I have no disclosures to report. Our training today is broken into 4 sections: the state-specific changes, new protocols added, protocols that were removed, and finally, review of existing protocols with changes. In order to make the protocols easier to read, additional formatting colors were added. The green ALL and red EMT sections remain unchanged. Ohio-specific sections are highlighted in yellow, Kentucky-specific in purple, and Indiana in orange. Some of these state-specific sections may call out the licensure level for that state by stating, for example, Indiana Medic. Now for the new protocols. Our protocol is a large document with an even bigger team of editors. Standardization of fonts, page breaks, and other formatting issues is important in a document of this size. As such, a protocol formatting guide has been added. Moving forward, all editors will need to use this template for edits or additions. Part of incorporating additional states into our protocol necessitates the addition of some boilerplate language that is required for the protocol to be approved. A new A115 protocol regarding the use of lights and sirens represents the first of these additions. This protocol only applies to Kentucky-based providers. The protocol itself has not been changed from the 2024 version present in the Kentucky version of the protocols. A116, bloodborne and airborne pathogens, is another Kentucky requirement. This technically only applies to Kentucky-based providers, however, it still contains useful information. There are no changes to the protocol from the 2024 version. P618, Safe Transportation by EMS Pediatric, is another Kentucky requirement. This protocol only applies to Kentucky-based providers, but again contains useful information. The protocol spells out the general concepts of safer pediatric transportation options. Appendix K is the last Kentucky-specific protocol added. This protocol has standard helicopter scene response safety information. It only technically applies to Kentucky, however, these practices are nearly universal. I have some good news with our protocols. As evidenced by the COVID-19 pandemic being declared endemic, special EMS treatment protocols are no longer required. The A112 Standards of Care during the COVID-19 pandemic and the M420 COVID-19 non-transport guideline are being removed from the protocol. While these protocols were useful in the early stages of the pandemic, COVID is now part of the new normal and is less deadly than previous. Continue to use appropriate precautions when dealing with respiratory symptoms. Now for the protocol revisions. The administrative protocol, A100, was changed this year. Individual agencies, in conjunction with their medical director, are now able to set their own operational staffing and paramedic response guidelines for their agency. This modification does not reflect a change in the standard of care, but rather gives the agency and their medical director the flexibility to make decisions based on that agency. A105, Determination of Death, has had several changes. Previously, the protocol spelled out signs incompatible with life. This, however, is hard to conceptualize and can vary greatly from provider to provider. In order to clarify things, the wording has now been changed to, quote, the patient's body is unable to undergo resuscitative measures, unquote. Specific examples are included. It is important to err on the side of beginning a resuscitation and calling medical control than on withholding the resuscitation. A Kentucky-specific section was also added, without changes, from 2024. Reflecting the differing laws in our three states regarding do not resuscitate orders, the protocol is now segmented into a Kentucky and Ohio section. Indiana providers should follow the DNR orders for their state. A109 was also segmented into three sections to reflect the different scopes of practice and medications available to advanced EMTs. It is important that advanced EMTs know their scope of practice and which medications they are authorized to use. SB 202, symptom-based respiratory distress, only has one change. Methylprednisolone, also known as Solumedrol, dosing was lowered from 125 milligrams IV or orally to 60 milligrams IV or orally. Literature indicates similar outcomes between these two doses with fewer side effects at the lower dose. SB 204, cardiac arrest, only had two small changes. A reminder and link was added referring to the M412 hypothermia protocol. A reminder was also added that in adult submersion injuries, no changes to cardiac arrest management are indicated. The Trauma Patient Assessment Protocol, SB 210, now has a Kentucky-specific section. SB 215, refusal of treatment or transport, had minor grammatical corrections. C300 VFib VTAC was modified slightly. Rather than have specific energy requirements listed, the wording was changed to defibrillate adults at the, quote, maximum energy per defibrillator manufacturer's recommendation, unquote. Additionally, there is some evidence that vector change defibrillation may be helpful in refractory VFib. As such, after 3 unsuccessful defibrillation attempts, paramedics should consider changing their pad placement. M400, acute coronary syndrome, now calls out the consideration of preemptive defibrillation or pacer pad placement. In a large development, Ohio EMT basics are now permitted to administer albuterol nebulizers independent of patient assistance. As such, M403, asthma and COPD, was updated to reflect this change. As previously discussed, the methylprednisolone dosing was reduced. We now have a broadened ability to treat nausea and vomiting via M405. The ondansetron, Zofran, dosing was increased to a range of 4 to 8 milligrams. Promethazine, also known as Phenergan, was added to the treatments available. This medication may only be administered to adults and only via the deep intramuscular route. The dose is a range of 12.5 milligrams to 25 milligrams. There are case reports of significant tissue damage when IV promethazine was inadvertently given intraarterially. Our psychiatric and restraint protocols for both adult and pediatrics had similar changes made. All now reflect, quote, life-threatening agitation, unquote, a change from the previous severe agitation. Ohio-specific sections were broken out. Kentucky and Indiana combined sections that do not reference Ohio law were added. Our seizure protocol, M410, had a minor dosing change to midazolam. Previously, intranasal midazolam dosing was much lower. It has now been raised to a range of 5 to 10 milligrams intranasal every 10 minutes until either the seizure resolves or a maximum of 10 milligrams has been administered. In an effort to clarify the use of cyanocobalamin, also known as a cyanokit, the M411 Toxicological Emergencies Protocol was updated. The protocol now reflects an easier-to-dose, age-based approach to pediatric cyanokit administration. A reconstitution and dosing sheet was created. It's recommended to print this page of the protocol and store it with the cyanokit. The medical directors also want to draw your attention to pediatric dosing for another reason. If you have multiple pediatric patients and are able to get multiple doses out of one cyanokit, you should split the cyanokit amongst the doses. Do this using a sanitary technique to avoid cross-contamination. For example, if 2 children ages 3 to 7 need a cyanokit, but you only have one, you should reconstitute the one kit and use it on both children. The stroke protocol, M414, specifically the CSTAT itself, was updated. The CSTAT is now a series of yes answers to get to 2 points instead of a combination of yes and no. This should make performing the test easier to interpret. Not surprisingly, the M422 Legal Situations in EMS protocol had to be modified for our 3 states. In this case, a Kentucky-specific section was added regarding their Safe Infants Act. Kentucky EMT basics are permitted to administer acetaminophen. As such, S505, pre-hospital pain management, was updated to reflect this. The traumatic arrest S509 protocol has several updates. In order to further distinguish the unique physiology differences between a medical or cardiac arrest and a traumatic arrest, the term cardiac was removed throughout the protocol. Additionally, the protocol was removed from the cardiac section and is now in the trauma section of the protocols. The administration of TXA may be considered in traumatic arrest, with the caveat that it not delay the overall arrest treatment. P604, pediatric SVT, now has a reminder to administer adenosine as close as possible to the heart to maximize effectiveness. As previously stated, Kentucky EMT basics may administer acetaminophen. P612, pediatric pain management, was updated to reflect this. One transportation consideration was added to P616, pediatric submersion injury. Cincinnati Children's main campus has ECMO capabilities. Their Liberty campus does not. In instances of ice water submersion injury, rapid transportation of pediatric cardiac arrest victims to the main campus is encouraged over Liberty. Our pediatric needle cricothyrotomy protocol, T708, had some minor clarifications added to reflect equipment recommendations. Additionally, a training video is now linked in the protocol. Let's watch.
All right, so let's talk about needle cricothyroidotomy. This is a complicated procedure. It's mechanically and intuitively simple, but there's a lot of moving parts. And there's a lot of conditions. There are a lot of moving parts and a lot of conditions with respect to a lot of things that we do, but we don't do this often. As a matter of fact, we do this very, very, very rarely. Hence, the anxiety that surrounds a procedure and why it is difficult to really keep these numbers in our head. I'm going to do my best to present you with a kit and present you with an algorithm for using the parts within the kit to perform the procedure and be successful doing so with little experience. The first image that you see is a close-up shot of the kit that we've created. This is a vacuum sealed kit, and it is sealed as such so that we are positive that the materials within are protected and that they are all there. The placard on the kit itself lists all of the materials in the kit, and it lists the name of the kit. If you are going to oxygenate someone that is less than 5 years old, you'll also need a bag. If you are going to oxygenate and ventilate someone that is older than 5, then you'll need some positive pressure delivery system. In our kit, I've built a transtracheal jet ventilator analog that will provide oxygenation and perhaps also some ventilation. This is a picture of the kit itself. As you can see, I'm opening the kit here by simply tearing down the side as you would with any of our other pre-made kits. This is the placard itself. You can take a second to study the placard if you wish, as it has all of the listed materials on it. It also has who put the kit together. It has the date that the kit was put together and the expiration date. Within the kit, we have several items. First is a Chlorhex swab for cleaning. We have sterile gloves for your use. We have one sterile blue towel. Now, with that said, as you can see, this is no longer in sterile packaging. I really built this kit for use in the field. I don't believe that this procedure will be accomplished sterilely in the field under really any condition, and thus I think that we should aim to do this procedure under clean conditions, and thus I've included the towel to help build a clean field and not necessarily a sterile field, and that's why I haven't put it in sterile packaging. Within the kit, we also have this particular device. This is the analog for the transtracheal jet ventilator that I referenced earlier. It's a piece of oxygen tubing with a stopcock screwed into the end, and we'll see how that's used here shortly. There are two angiocaths, a 14-gauge angiocath and an 18-gauge angiocath. The 18-gauge angiocath should be used for patients less than 5 kilograms. All other patients should have the 14-gauge angiocath used. Of note, these are older style angiocaths that don't have any kind of locking mechanism, and that is very important. There is a saline flush, and there is another device. This device I call the jumper. As I referenced earlier, for patients less than 5 years old, we're not going to use a transtracheal jet ventilator, but rather hook up a bag valve mask to the system. This is because smaller patients can be harmed by those high pressures. This is simply a way of connecting the angiocath that will serve as our conduit into the airway to that bag in a flexible type of conformation so that it doesn't apply too much traction to it and cause kinking. This is that blue towel that I included to make a clean field. You can see me doing that here. I'm taking out our 14-gauge angiocath and putting it onto the field. I'm taking the jumper and putting it on the field. I'm taking the saline flush and putting it on the field. And I'm taking our jet ventilator, quote unquote, and putting it on the field. I'm opening up sterile gloves, and I'm opening up our Chlorhex swab for cleaning. These are the rudimentary materials that you will need. I have not opened up an 18-gauge angiocath. If this were a patient that was less than 5 kilos, I would open up that. So let's narrate some of the steps of actually doing the procedure. First, I would take the Chlorhex swab and clean. Then I would apply sterile gloves. Then I would prepare the angiocath for use. Our angiocaths have this small plastic piece that's on the back of it that need to be removed, as you can see me doing here. I'm attaching the angiocath to our saline flush. I'm locating the anatomy now. I think for this procedure, it's easier to stand on the patient's left. I've located the cricothyroid membrane. I'm going to puncture the cricothyroid membrane as is shown. I'm going to take care to make sure that I'm pointing inferiorly and not superiorly so as not to traumatize the vocal cords. I'm going to advance slowly while applying suction force to the plunger, just like if I were doing a central line. The reason for doing this is that as you advance, once you hit the airway, you can start to appreciate bubbles coming into the saline solution. As soon as those bubbles are apparent, then you stabilize the system with rigor and force. At that point, you can take the angiocath and slide it into place using standard technique. After you have taken the needle and the syringe out of the angiocath, take the needle off of the syringe and then reapply the syringe to the angiocath that is living in the patient's airway. Then reapply suction force to make sure that bubbles are still coming from the angiocath itself. There are several reports of going through the airway when this procedure is done, and there are several reports of the catheter being kinked or lodged in the mucosa. By reconfirming after you've taken the metal out of the angiocath that you still have bubbles, that really gives you some security that you're in the right spot. The next step will be to choose whichever oxygen delivery method is appropriate for the patient. If the patient is less than 5 years old, pick the jumper that I mentioned earlier and screw it onto the angiocath. You can ventilate using a bag valve mask through the jumper and then through the angiocath itself. Make sure to take care to disable the pop-off valve on the bag, as you are going to need high pressures to actually give breaths through this small tube. If the patient's older than 5 years old, you use some type of jet delivery device. You can either use the one that I've included in the kit, which you see me extending here, or you can use that commercially available one that we showed earlier. The reason why I like the one that we have built is that it is one-time use and it has no mechanical parts that require service or maintenance. To use this particular device, hook it up directly to wall oxygen and hook up the end of the stopcock that has the lure fitting directly to the angiocath. Turn the oxygen on to 1 liter per minute per year of life. And by that I mean, if you have a 7-year-old patient, put it on 7 liters per minute. If you have a 12-year-old patient, put it on 12 liters per minute. I would go up to 15 liters per minute max for any adult patient. To actually deliver breaths, simply cover up the open orifice. To allow for passive exhalation, take your finger off of the orifice. Now, it is important to note that during this particular procedure, there will be no ventilation through our system. All of the ventilation will be passive from lung recoil and chest wall recoil. If the patient has complete and total upper airway obstruction, you need to take care to make sure that you are not overinflating the patient's thorax and causing barotrauma. Now let's discuss using the commercially available jet ventilator. This hooks up directly to some oxygen source, not through a regulator, but rather just to full pressure. This goes to a regulator within the device where you can dial in PSI. For ages 5 to 12, use 25 PSI, and for ages 12 and older, use 50 PSI. After you have hooked up the jet ventilator to the angiocath, you can depress the button that exists within the system to actually deliver breaths and let off of the button to allow for passive recoil. Now let's be very clear. If you're using the commercially available jet ventilator, you will be working with very high PSI. The jet ventilator analog that I built is a higher pressure system than using the bag. However, the PSIs do not approach that of the commercially available system. The pro of using the commercially available system is that because of those higher PSIs, you will induce some ventilation through chest wall recoil and by simply inducing gas exchange from the alveolar spaces.
The hemorrhage control protocol T710 had some minor updates. In addition to packing wounds to the groin, axilla, and neck, limbs are now added. It's important to hold direct pressure following packing for at least 3 minutes. If the bleeding is now controlled, reassess the patient and apply a pressure dressing. Wrapping things up is our imminent delivery protocol O800. A reminder is included to prevent hypothermia and to keep the newborn warm. Some additional transportation considerations were added. Specifically, it is preferred that both mom and newborn are transported to the same hospital. Skin-to-skin contact, also known as kangaroo care, is an effective means of preventing newborn hypothermia. Each agency, in conjunction with their medical director, should develop a policy regarding field-delivered newborn transportation. Several transportation devices are referenced, but not endorsed, in the protocol. Lastly, if mom and baby are both stable, consider delaying transport for up to 20 minutes to allow for skin-to-skin contact. An additional technique for breech delivery was also added. We have a video to show. Apologies for the quality.
In the modified MSV maneuver, the trunk of the fetus is held astride the right arm like a saddle. The index and middle fingers of this hand are placed on the baby's cheekbones. Remember, no finger is placed in the baby's mouth. The other hand is placed on the fetal back with the index and ring finger hooking the shoulders. The middle finger is placed on the baby's occiput, holding the baby in this manner. At the height of a uterine contraction, a firm downward traction is applied, and at the same time, the baby's head is gently flexed towards the chest to bring the baby's head down until the hairline is visible anteriorly and the chin is delivered posteriorly. At this juncture, the fetal trunk is elevated towards the mother's abdomen until the mouth and the nose are free. Thus, effectively, the aftercoming head of breech is delivered by flexion.
That wraps up the 2025 Academy of Medicine of Cincinnati's EMS Protocol training. These protocols require significant input from a large group. If you want to help update the protocols, please email me at the email listed below to be added to the email list. The Academy of Medicine of Cincinnati's website is the official repository of these protocols. You can find them at academyofmedicine.org under the Allies in Medicine header. Thank you and have a wonderful year.